guess we're going to go ahead and start. So basically, I'm going to give you a talk on sex and aging. The reason I'm doing a talk on sex and aging is I did one 15 years ago in Rome, and then I got asked to do one at the Malaysian Geriatric Association talk in Borneo. And in return for going there, they flew me in to see the orangutans. But the talk they wanted was sex and aging. And if you ever want to try and give a talk on sex and aging in a Muslim country, it's not that easy. So that's all I had to say. So I'll try and be a little more open than I was in the Muslim country when I gave the talk. Though the best talk I've ever heard on sex and aging was given by 3 young women from Malaysia who were at a medical student conference. And they stood up, all totally covered, and gave this wonderful talk about how older women felt about sex in Malaysia. And I have never heard a better talk on sex. And how they managed to do this, I have no idea whatsoever, but they've never published it, so I think they most probably upset every single professor they had and everybody else. But they actually finished up second in the competition, the Asian Australian competition. They would have been first if my vote had counted more. So really, so sex is important for everybody, and it doesn't disappear. It does change forms as you get older, and clearly this can change the work. Okay, so basically, Sappho, many years ago, said, "Do you not realize that age has wrinkled all my skin, that my hair has become white from being black, and that I have hardly any teeth left, or that my knees can no longer carry my body back again to the old days? I joined in the dance like the fawns, the numberless of living things. And now this is enough for me, that I have your love and I desire no more." And most of you hopefully know the story of Tithonus, and he was the morning lover of the goddess of dawn, Aurora. And basically, as a goddess, she had a morning and an evening lover, but it turned out that Tithonus was so good at what he did that she did not want to lose him. So she did what any goddess would do. She went to the god of gods, Zeus, her father, and said, "Gee whiz, daddy dearest, I need to have this guy alive forever." And what happened is Zeus took a thunderbolt out of his pocket, and Tithonus had eternal life. The problem is she forgot to ask for eternal youth. So as the story goes, somewhere around about the age of 50, libido was a problem. By 70, potency was pretty awful. By the age of 80, he was sort of getting weaker and stumbling around her castle. And when he reached 100, he developed mild cognitive impairment, and he went around her castle mumbling incessantly. At this stage, she decided she didn't love him anymore, and she would like to get rid of him because he couldn't do whatever she wanted him to do. But she couldn't kill him because he had an eternal youth. So she basically, listening to him muttering around the castle, she turned him into a cicada. And when you hear the cicadas chirping, that's just a group of old men muttering incessantly. Okay, so this is perhaps a book that certainly any older person, any person who works with older people should read if you haven't read it. It's a wonderful novel out of Colombia by Gabriel Garcia Marquez, and he talks about fundamentally her shoulders were wrinkled, her breasts rugged, her ribs were covered by a flabby skin as pale and cold as frogs' legs. Yet he saw her just as he had imagined her. Despite the travails of partial erectile dysfunction, they eventually clumsily succeeded at intercourse, but in the intervals in between are satisfied simply with the joy of being together. And it's a story of about a guy who spent his whole life trying to catch this woman, and he caught her when she was 70. Okay, and really a beautiful story, so worthwhile reading. And fundamentally, this sort of cartoon sums it all up. Sexuality is an important component of emotional and physical intimacy that men and women experience throughout their lives. And if you look at intercourse in older females, the studies go all over the place. So Any high values you see there are Berkeley, California. So for some reason, and done sort of just after the 60s in Berkeley, every woman in Berkeley was having sex up to 102, okay? But everywhere else are closer to the lower values. So that's where the high values come from. And you can see that about a third of women 60 to 70 are still having intercourse, 70 to 90 about 10%, and over 80 it's still around about the 10%. On the whole, older females and males have sex about once a week. About half of females masturbate up into their 70s or 80s. My favorite two patients were in the nursing home at Maryland Heights, who basically they found a set of forks that they'd stolen off the kitchen table, and they were sitting there, and the two of them were using them to masturbate with in there, and they were both in there. One was 85, the other was 90, and they seemed to, don't pull your face, it's fun. I mean, you know, sex is fun. Okay, that's what I'm trying to teach you guys. There's nothing wrong with it.
You can think of a lot of other things in a fork.
Well, you know, not when you're stuck in a nursing home. You don't necessarily have anything better. And apparently it worked really well. Okay, so you should try it sometime. That will be what I have to say at this stage. Okay, and 73% enjoy intercourse, and there are a third of women who tolerate it. But that's exactly the same figure you get at 20. So nothing changes about the toleration piece. Okay. So when you look at aging, this is from Masters and Johnson, there's a decrease in vasocongestion, nipple erection, you get spastic painful contractions more often as you get older, there's decreased tenting in the cervix, you get a decrease in congestion of the labia majora, a decreased separation of the labia majora, obviously lubrication goes down, and there's a decrease in the orgasmic platform contractions. This has been done by Masters and Johnson up the road in Washington University, and I assume all of you watched the HBO series on Masters and Johnson and basically realized that they did things that were totally unacceptable in St. Louis at the time that they did them, which were in the 60s and 70s, and they were really great characters, the two of them. So the major sexual concerns of women and men are orgasm, not having good orgasms. A lack of interest is a major one for both groups. Lubrication in women, really most probably the major complaint that you're going to get from most older women. We'll talk about that. Then basically getting to the pre-orgasmic stage is a problem. Women complain of partners. When I was coming back from Chicago once and I was trying to finish writing a paper when I was younger, I was sitting in first class and I basically thought, well, I don't want whoever sits down next to me, I don't want to talk to them, I just want to work. And then in came this elderly lady in her 80s, and I knew she was going to sit next to me, and I knew she was going to talk, and I tried very hard to avoid her. And nevertheless, she managed to start talking to me, and it was the best time I've ever had. She was the editor for Playboy magazine for the January abnormal sex issue, which is what she did. So she'd done this with Hugh Hefner for like 30 years, and she was my companion. And it was the most fascinating life I've ever had. I learned more in that 2-hour flight to St. Louis than I've learned anywhere else. And she said Hugh Hefner is actually quite a nice person. And it turns out, by the way, that she was a very staunch Methodist, sung in the Methodist choir, and had been married for 60 years and had never had another partner. Just so you recognize who writes Playboy magazine. But of course now they've changed and they have none of this anymore. So this is the new Playboy magazine, so just in case you didn't know. Dyspareunia is a big deal in older women. Family planning. I don't actually know why that's there, but I think that comes mainly from men, that they think they need to family. So this is like Mr. Trump, he needs to family plan because he can't afford to have many more children with 35-year-olds, which I understand is the cutoff for what he's prepared to accept. No, it's just how life is. It's not my fault that he said that. Safe sex is still a problem in older people. Sexual aversion and extramarital affairs are all problems as you get into older people. So management of sexual dysfunction in older women, and this is important for all of us to recognize. If you don't ask about it, people don't tell you. So you can assume that none of your older women or men are interested in sex. Obviously, if you ask, you find out that lots of them are interested in sex. When we first started doing this stuff in Minneapolis, it was the job of the residents, because we were doing a study. No male could get out of the VA when he came to the outpatients without having had answered and having a little card that came back with him about whether he was impotent or not. It was almost impossible to get the male residents to ask this, and the patients would get sent back 5 or 6 times, because the clerk, it was very funny. She would just send these guys back to the male residents to say, you've got to fill out this card before you can leave. The female residents had no trouble asking the questions. So this is basically a piece to know that apparently females can do better than males at asking questions, but it's also listening. So you ask, is there a problem? But you need to listen to what the person tells you. A lot of sexual, looking after people who have sexual problems is just telling them it's okay. You know, remember that it's not your decision whether or not what they do is right. You should not be telling them, and the only time I think I've ever told somebody that what they wanted to do was wrong when 2 males came to me and they wanted to know how to remove the testicles of the female of the 2 partners, because that is actually one of the ways that homosexuals show they love one another. And I could not bring myself to tell them how to do that. I did mention that there was easy ways to do it on the internet. By the way, it's commonly done, and it's very easy to get rid of the male testicles, just in case you wanted to know. But I could not give permission to that one. I failed, okay? You always need to provide information, so I sent them to the internet, so I did what I was supposed to do and left it at that. Specific suggestions. Important to know something about vibrators and to remind people that vibrators work as well, or if not better than forks, okay? Paraclitoral stimulation is very important for many older women to get complete stimulation. And then lubricants, and we'll talk about those in a minute. And then sex therapy is right at the end. You, the average physician, nurse practitioner, should be able to handle most sex things with older people. The biggest condition that you deal with in menopausal women is the hyperactive sexual desire disorder. It's about 1 in 10 women at the time of menopause. What happens is they just lose total interest in sex. And it's a huge problem if you're married, and you're happily married, and now you don't want to have sex. You find it repugnant to have sex with your male partner, and it messes with the marriage, basically. So recognizing that there are a number of causes. Depression is a big one. Fatigue, sleep apnea, a very big cause of hyperactive sexual desire. So you have to look for these things. People who are overtreated, their high blood pressure is overtreated, hypothyroid. People who are having pain and fungal infections all the time, so you have to look at those. Vaginismus, not that common in women who are older, but in sort of younger women when they first get married, you have a subset of younger women who, when you're going to have intercourse, their vagina just contracts and clamps down, so it makes it impossible to have intercourse. It's called vaginismus, and you treat it with Botox now in the modern day and age. There were many things before, but now it's treatable with Botox, something to be aware of. Dry vaginas, you don't tell them to go and use the classical lubricants we use to do rectal exams. There's Astroglide, which works very nicely. Olive oil works as well as Astroglide. So not only can you swallow your olive oil so you live a long time, but it's also an ideal agent for you to have better sex, okay? Not my fault, it's just how it is. Vaginal estrogen or SERMs, this ospemifene is used fairly classically by gynecologists. for people who have a dry vagina. Trazodone actually increases clitoral blood flow, so it actually is not an unreasonable drug to look at. Flibanserin is only supposed to be used up to the age of 50, not over the age of 50. It increases the number of sexual events by about a half event every 2 to 3 months. It's not very good. It's a mixed serotonin agonist antagonist, and it causes dizziness, fainting, sleepiness, and nausea. Should not be given to older women. And then there are a lot of other things that are not marketed but are being tested. Oxytocin increases orgasms fairly dramatically in women. Bremelanotide, which is a MSH, melanocortin receptor agonist, actually also increases orgasmic ability.
So were your older ladies in the nursing home on trazodone?
My mother, Dr. Grossberg, just with my mother on that. Do I need to be a...
Well, you know, it's not my fault. She will most probably be happier. Okay, all I'm trying to tell you is sex makes you happy, not unhappy.
So really, if we have those ladies in the dementia unit that are on trazodone that are having sexually inappropriate behaviors and that sort of thing, which we have from time to time.
So yeah, I mean, you've got to, this is one of your choices, is you want to stop using the trazodone to calm them down and not have the sexually inappropriate, you switch to something else. But trazodone works fairly well, you've got to recognize that. Okay, estrogen is needed in early menopause and severe flashes or poor bone mineral density. So any woman who's under the age of 52 and has menopause needs to have estrogen. And please don't believe the Women's Health Initiative, which I'll show you what the data really showed, to say they should not go on estrogen. Under 52, estrogen is going to improve your bone. It's also going to decrease cardiovascular disease, and it's really important. Post 52, up to 5 years, is the accepted use of estrogen in women, and if you don't have to add progesterone, it's extraordinarily safe. So if you actually have had a hysterectomy, estrogen is safe. If you haven't had a hysterectomy, it's not quite as safe with progesterone. If you've got to use progesterone, you lose the lowest dose you can. You can use 5 years post-normal. And tibolone, which is not available in the States, but is commonly available in Europe and Asia, is a mixed SERM, which is a mixture of a testosterone agent as well as an estrogen and progesterone agent. It works very well. It has more effects on bone and muscle as well as on sexual activity. So this is the Women's Health Initiative. And if you look here at estrogen alone, you get maybe a little bit of an increased stroke, but everything else, really, estrogen is pretty safe. And when you look at cancer, fractures, and deaths, there's really no increase with estrogen alone that has any meaning. So fundamentally, relatively safe, even that's beyond 50 to 59. If you look at it over 50, at 50 to 59, it's totally safe. So estrogen is extraordinarily safe in younger women. The Women's Health Initiative, which has put everything together, did marked disservice to women. And a lot of women, gynecologists stopped putting them on at 40, and I was seeing them at 50 with hip fractures, which they should never have had. So
I don't see dementia on your list there. So now in these little flyers for estrogen, it talks about the risk of dementia, particularly in women over the age of 65.
So again, in older women, some of the data suggests that estrogen in older women will accelerate dementia. Does not suggest that in younger women. And if you look at the 50 to 59, you're decreasing the reasons for dementia, which are basically usually vascular disease. So very happy at your age. When you get to my age, it's a problem. Okay, how about that? But I'm not going to take estrogen, so let's put this in perspective. And I should never be given to men. So what about testosterone substitution? The only reason to talk about this is there are tons of gynecologists around the United States who are starting to think this is a great thing to do for women. There's very limited data. So testosterone, women drop their testosterone about 4 to 5 years before they lose their estrogen. and it may go up a little bit right at the end of their life. In women, testosterone clearly increases libido, increases general well-being, it gets rid of nostalgia, it decreases headaches, it increases bone mineral density and muscle mass. And there's data for all of this, but these are not huge effects. The intrinsic study, which was a patch, showed minuscule effects on sexual performance, which was the reason the FDA did not approve it. It didn't go the studies, only went for a year or so, so you don't see side effects. A lot of women use compounded vaginal creams with testosterone. Testosterone undecanate can be taken either orally or as an injectable. Estrotest, which is a combination of estrogen and methyl testosterone, not really used in the States, but commonly used throughout Europe, for instance. DHEA doesn't really work, and so you shouldn't use it. Testosterone patches, pellets, and gels are commonly used, and the pellets are most probably what's most used by gynecologists at this moment in time. Nasal testosterone is now available. The question over there is what kind of women seek pellet therapy. I can't tell you, okay? I have no understanding, and there's no literature. This is the problem. We're literature less about this. Natesto, which actually I was involved in the early development of the nasal testosterone that's now available. Actually, we showed way back that in middle-aged women who got a single nasal dose of testosterone, they rapidly increased amygdala reactivity to the level of young women. So it works actually really well on the emotional components in a middle-aged woman. So for what it's worth, it's there. Whether you should use Natesto, it's most probably safer than using pellets, and it most probably has a slightly more instant effect, so you only have to do it once a day. Okay, so any questions about women before I go to men for the next half hour? Or are you all too afraid to ask questions? So, I mean, it's a big deal for women, and it's becoming a bigger deal. And we have to recognize that as you get more and more women who are going to be sexually active into their 80s and 90s and expect to be, it's our job to ask about this and be aware of it. And, you know, we have on our first entry into, the thing we do for the initial visit, there's a sexual question there, and I virtually never see it asked anymore when I go looking. People somehow manage to forget to ask the 90-year-olds and the 80-year-olds are they sexually active. And let me point out that because they don't have a partner does not mean they're not sexually active, and because they've got a partner doesn't mean they're not sexually active, but maybe not with their partner. And this is when you ask the question, you get shocked or surprised. You can take your choice what word you want to do, and how many different versions of sexual activity are going on in older people. It's not unusual anymore. If you went back to my mother or my grandmother's period, it was very rare to see this, but this has changed dramatically. And you need to be aware of how to help people not find sex as an unacceptable thing, I think, more than anything else, and particularly for women.
I have a question. So, would pellets hurt my mom at the age of 83? Because I, at the age of 48, had instruction me, I get pellets, and I love my
You don't have to share with everybody,
Right,
Sherry. Thank you for sharing.
I think it's
You see the problem with the modern woman, okay? That's the end. Now you've embarrassed all of us.
But do you think that they would help an 83-year-old woman just with her mental state?
So the problem is, it's very much, we're going to talk about testosterone in males. It's the same sort of thing. There's limited data outside of the fact that there's some improvement in sexual activity and some improvement in muscle strength. There are no long-term studies really in females at all, and even in men, not very good long-term studies that say what the side effects are. So the question is, if I take testosterone and my levels are somewhere around a normal male's levels in my menopause, what will that do to me? You have to, I didn't say, but you do have to get laser therapy on a regular basis for the hairiness, and that's one of the common side effects. But what else is it doing to your body? And we have no idea. You know, is it going to make you demented? Is it going to make you, is it going to kill your heart? We don't know. There's no data. So with no data other than a year or 2 year data, you can't recommend this stuff. If you recommend it, I would recommend the nasal testosterone because you get the same effects with a very small dose, that very little of it gets out into the periphery. So I think nasal testosterone is better. Theoretically, I may actually stand to get a lot of money from this because I had a contract with the people that they've never paid me for, and now that the product is actually on the market, somebody may give me a lot of money, so I really want to sell nasal. I don't want to sell nasal testosterone.
Does insurance and Medicare pay for it?
You know, most probably not. There's no data. So we lack data. When you lack data, things don't get paid for. Somebody has to do studies. Yes, Walter?
When you say it works just as well, you mean it for the sexual dysfunction, not necessarily for
We're talking about the sexual dysfunction and basically the emotionality stuff. And it's instant.
Because
So
sometimes women will seek it for other effects, like other peripheral effects.
Strength, the massalgia, it's most probably not going to work for most of those. Though it does get the testosterone levels up to about the level of a high normal woman's, between 50 to 100. So it will be higher at the level of polycystic ovarian disease testosterone. That's about where the levels, but those are still lower within the normal range for women. It's not what the pellets do, which is put them at about, most probably higher than my level, but that's okay. You know, that's how they work. So recognizing that, the other thing about Natesto is because of the MRI study, it works instantly. So it's not working on the testosterone receptor, it's actually working on membrane receptors. So it's totally different from what you would expect. Okay, any other questions, or have we finished women and can we go to bed, which I feel much more comfortable with? Okay, so men I've been doing forever as opposed to women. And basically, if you look at it, this is again the Masters and Johnson, that as you get older, you don't get testicular elevation, you have, it takes longer to develop an erection, and there's a decrease in scrotal vasocongestion. The second phase, your erection tends to be soft, and there's less pre-ejaculatory secretion. When you go to the third phase, the first phase of orgasm is decreased, the expulsive force is decreased, and you have less urethral contractions, so the orgasm is less strong. You have rapid detumescence with slow involution of the vasocongestion and rapid testicular descent. So older men often complain of pain post-intercourse, and that's the vasocongestion that occurs. And then basically the ability to start again is prolonged much more than you would expect. So erectile dysfunction is the consistent inability to attain and maintain a penile erection sufficient to permit satisfactory intercourse. Soft erections often don't allow satisfactory intercourse, and they may be the biggest problem that you see early in older men in their 50s to 70s. They come with soft erections, not with inability to get an erection, but it's just soft. When you look at how prevalent this is, in the Massachusetts Male Aging Study, which was looking at people 40 to 70, about 52% of these men have some degree of erectile dysfunction, complete in about 1 in 10, moderate in about a quarter, and minimal in about 20%. And you can see that the age progression is markedly increased, so that by the time you get to 70, about 70% of males have some degree of erectile dysfunction. This is a study we did when we first came to St. Louis University, looking at the causes. We had 310 males who came to us for erectile dysfunction. In those days, we were most probably the only place in the Midwest that actually dealt with males who had erectile dysfunction. This is pre-Viagra, all of those things that are to come. And basically, we found that about the males under 60, about a half of them have vascular disease. But the cause over 60 is predominantly vascular disease. And I'll show you in a minute that you've got to pay attention. If a male tells you they're impotent, You're much more worried about how their heart is working than you are about whether or not they can get an erection. Endocrine and depression, very common in younger men, much less common as a cause as you go to older men. So this is, if you measure penile blood flow and you look at it, fundamentally people who have impotence and they have poor penile blood flow, less than 0.65. You have a little blood pressure cuff you put on the penis and you measure it with a Doppler. We used to do this all the time, and it works very nicely, and you compare it to the brachial blood flow. But if you look here, you see that in a year of follow-up, if you have low PBI, 12% are going to have a myocardial infarction, 16% are going to have a stroke, and the major vascular accidents were 1 in 4 of these patients. So low PBI, very high chance of having a vascular accident. You can do the same thing by measuring peripheral blood flow in the legs. This is virtually the same. If you have equivalent blood flow, poor blood flow in the legs, exactly the same thing. So the penile artery, same size as the coronary artery, and if your penile artery has poor blood flow, your coronary artery has poor blood flow, is really what you're looking at, and you need to pay attention to this. So one of the most important things, if you want to stop people smoking, I have stopped more males smoking in this than anything else, is that if you smoke, you're more likely to be impotent, and you're going to have decreased penile blood flow. But importantly, if you smoke 2 cigarettes and you have a papaverine injection which gives great erections, they get no erection at all. So if you tell males that this is the problem, you don't tell them about heart disease, you don't tell them about lung cancer, COPD, they don't care. But they really care if you tell them they can't have erections. It's the easiest way to stop a male fundamentally smoking. So now we come to the blue pill, which is the new blue moon, you know, for you going out if you're a lover, you can have great moments. And so the phosphodiesterase inhibitors have come along. There are a number of them that are available, sildenafil, vardenafil, taldefil, and Aventil are available in the States. The other 2 are available in the rest of the world. So many years ago, that would have been 1989, before most of you were born, so somewhere back in those days, we were trying to work out how to improve blood flow to males. And we knew that pentoxifylline or Trental improves blood flow in the legs, so we decided we could also use this to improve blood flow in the penis. And we actually showed that we could do this to some extent. It wasn't a great drug, but it worked for some males. And actually, we first basically, I went to Saudi Arabia because the Saudis are very interested, the male Saudis, in sexual function. This is basically, they paid me a huge amount of money. It's the second most money I've ever got. Once I did a launch for one of the drug companies for testosterone, and they had one of their products, and they gave, I think it was, I don't know what it was, some stupid product, okay, not very valuable. They gave me $25,000 to speak to their people, but the Saudis gave me $20,000 to go to Saudi Arabia for a week and teach them how to deal with impotence, which tells you how Saudi men feel about impotence, okay? Anyhow, we first published in a Saudi medical journal, then in the medical clinics and a variety of other places. This is important because 20 years later, along came all the things that were like Viagra, and what happened is that Pfizer said that nobody could put these other products on the market because they had patented every type of phosphodiesterase inhibitor. And hard to believe, but the Bayer and the Lilly lawyers actually found that we used pentoxifylline, worked out that pentoxifylline was a phosphodiesterase inhibitor, which I had no idea at the time. They called me, and they paid Sue a large amount of money for us to write letters saying that we had used this before Viagra came on the market, and we had. So we actually discovered Viagra, if you like, and all the others, but we were too damn stupid to know. So my yacht in the Mediterranean doesn't exist, otherwise it would exist at this moment in time. One of the many times I failed. So basically, to get an erection, you need nitric oxide working through cyclic GMP, and VIP and acetylcholine will also cause relaxation of the corpora, and norepinephrine and endothelin cause contraction. This is why when a male has a bad episode and then they stress the next time, they don't do as well. So if you start to have impotence, your impotence gets aggressively worse because you're stressed, your norepinephrine goes up, and that causes problems. So it doesn't matter which PDE5 inhibitor you use, they're all equally effective. Sildenafil has slightly more adverse effects than the others, but mostly people think that it's a treatment of choice. The major side effects are headaches, flushing, and most importantly, dyspepsia or GERD, because people think of it as chest pain. The reason for this is that PDE5s occur in the eye, in the penis, and in basically the fundus of the stomach. So when we were being created, it obviously you have to be able to see that the person you want to have sex with is there, or the animal is there. Secondly, you've got to be able to have sex. And the third thing is eating is pretty good too. So this is how we enjoy life. So PDE5s are the enjoyment of life, if you want to look at it that way. Failures, poor sexual stimulation. These drugs do not work unless you have sexual stimulation. So if you don't tell the patient to do this, it doesn't work. And this is the most common reason I see people who are taking Viagra, they come back and they say, it's not working. And you say, what have you done? Well, I'm testing it because I don't want to go and try and have sex with a woman if I'm going to fail. So I'm taking it, and of course nothing happens. Okay, so that's how it is. People are very stupid. Okay, poor education. Physicians do a terrible job educating people about the PDE5 inhibitors. You can try up to 6 doses because sometimes it takes time for it to work. Daily dosing works actually better than once, and it's paid for Cialis as long as you give it for lower urinary tract symptomatology. So you can give 5 milligrams of Cialis regularly because PDE5s improve urine flow in older males, but you've got to say you want it for that, not for sex. You can give combinations of a variety of drugs, and obviously you need to stop smoking and control diabetes. Efficacy starts at about 75%, goes down to about 60%. The other options are psychological. You always talk to the male and make sure you know what the problem is, because if you don't know what the problem is, you will get caught that they have some weird sexual thought or something, and that's what they're really trying to get fixed. And you're trying to fix an erection. Make sure that they want the erection fixed. Make sure that they know what they want before you get into it, and make sure that you're not just trying to fix a marriage by getting an erection, because it gets you into trouble all the time. The drugs are PDE5 inhibitors. Apomorphine works very nicely. The problem is it makes you vomit. So you have sex and you vomit on your partner. Not a good outcome. Okay. Intraurethral stuff, this is alprostadol mainly. It doesn't work very well. And sticking something into your urethra just doesn't make any sense to me, but there are males who will do it. Okay. Intracavernosal injection, you teach the male to inject papaverine, phentolamine, and or prostaglandins directly into the penis. It's very easy to do. Okay, no problem, and many men can do it. About 90% will get a positive effect. So that's actually the treatment of choice. Otherwise, you go to vacuum tumescence devices, which are these things you put over your penis, you pump it up, you get a vacuum, you slip a rubber band over the base of the penis, and voila, you now can get rid of the vacuum tube and you can have intercourse. They actually work. The problem is it's a huge, it's a kinky sex thing. So you've got to make sure first that the partner is into this form of kinky sex, because large numbers of women reject having this going on, and so they don't want to have sex with the guy after he's done all this. So you've got to check. And by the way, don't give them a prescription for it. It costs about 5 times as much, and the ones you get from prescriptions are not nearly as good as what you get from the local sex shop. So either go online and find them online, or send them to the local sex shop to choose one. They're much better than the medical devices, okay? And then penile prostheses. If somebody is 50, 60, 70 and wants to have sex for the next 20 years, penile prostheses are the answer. You don't want to basically mess around with all this other stuff, which often doesn't give you an adequate erection and so on and so forth. What about sex and testosterone? Basically, going back to 8th BC, we knew that testosterone improved sexual performance. So you had the eunuchs, the Ottoman Empire, the head of the Blessed Chamber, to make sure he wouldn't go chase the women. Basically, he was castrated, and people who were believers in God or gods, the sun castrates for Ra, the Scots, which are a Christian sect in Russia, have their testes chopped off so that they won't pay attention to women. And in fact, this was fairly common in the Catholic Church in about the 16th and 17th century, that many of the priests would have their testes removed and become the castrati, because that meant that they wouldn't chase women. That was the origin of finding out about castrati. The hijara in India these are runaway boys who are brought into the sect, and they cut off their testes, and they come and sing very badly at weddings in India. And you've got to pay them to go away. And if you don't pay them, your wedding will fail. Okay, so this is a big scam. It works really well, and for little runaway boys in India, they make a lot of money out of it. Just to point out that in the Ming Dynasty, where there was lots of the Sun Yat Ting, actually lived to 94 years old, suggesting that testosterone isn't that important for living a long time. So basically, Brown Sequard in 1889 decided that he was 70 and he was no longer able to do what he liked to do, which is go to work at 6 in the morning, come home at about 6 or 7 in the evening, eat, and then read his medical journals till about midnight. And he felt that he had to fix this, and he did animal experiments, and he showed if you squashed up testicles and injected it into the animals, they seemed to function better, and he injected himself with animal testes, made properly, I think, because he showed that he could increase his urine stream, and that's how he measured whether it was working or not. And it's actually true. Testosterone markedly improves urine stream in older men. So he did that, and he said he could now read his journal. Voronov, who came out of Russia, went through Algeria, where he saw all these baboons, said, wait, I've got a better idea. Baboons look just like men. And so when he got to Paris, he started to do baboon transplants. And every rich male in Europe went to see him and got their baboon transplant. So Brinkley in the United States, in Kansas City, said, well, if it's okay for baboons, we've got a shortage of baboons in the United States, so what should we do? And he started to do goat gland transplants, and he was very successful with the goat gland. By the way, Angora goats you can't use because they smell, the testes stinks, so he found that out.
Where do they put? I mean, I'm confused.
Wherever you like.
Where?
The testicle?
Into your stomach and wherever you want. It's not a big deal. It's a transplant of a testes.
It doesn't reject or anything?
Well, some of them obviously did, and some didn't. A lot of this is placebo. I'm not even arguing that this stuff is 90% placebo, but this was done at the University of Chicago, and there they was working really well. They had their monkeys they imported to do it, and they were doing really well. And then guess what happened? The monkeys escaped, and they were, according to the Chicago Tribune, found on the altar in the Catholic Church masturbating. This is the story. Not true. I'm just telling you what you get of this. This is total nonsense. Okay, I'm just trying to give you the history. So in the 1930s, to be fair, the world changed, and in the 1930s, Ernst Leckert, Organon, isolated testosterone from testicles. Adolf Butenandt, being a German working for Schering, collected 25,000 liters of policeman urine, and he found a testosterone metabolite that would work. And Leopold Wutzke, being a Swiss working for Kieber, made testosterone from cholesterol. So since the 1930s, testosterone itself has been available. We know as people get older that testes don't work as well, but more importantly, you lose circadian rhythmicity, and LH basically doesn't work as well either. So you have a problem in the hypothalamus and you have a problem at the periphery, which leads to a decline in testosterone, and this starts in males somewhere around about 30 with a decrease of about 1% to 0.5% per year starting at 30. Okay, so that's how it is. Diabetics are more accelerated. So diabetics, you see the same thing 10 years before in the diabetic patient. I'm not going to tell you this because we're running out of time, but testosterone combines itself to the CAGs, which are their receptors. The receptors go in, activate the nucleus with 2 testosterone, and then fundamentally the testosterone is rejected and you get your testosterone effect. And it's much more complex than that, but I'm not going to spend any time on it. So what you have to recognize is testosterone circulates bound to sex hormone binding globulin and to albumin. The sex hormone binding globulin bound testosterone is not available. With aging, there's an increase in sex hormone binding globulin. So the testosterone, total testosterone is higher, but the bioeffective or bioavailable, which is the albumin and free, is actually lower. So if you just measure a total testosterone, it's not a good measurement in older people. And basically, we and the Mayo Clinic showed that actually levels as high as 400 would, in a 70-year-old male, greater than 400, about half of them are actually hypogonadal. So you should be measuring a bioavailable or a true free testosterone. That doesn't mean send it to the SLU lab where they run a make-believe free testosterone that has no value whatsoever. So send them to Quest, basically, or LabCorp are the only 2 places that do them. The important piece here, really, is the other side. If you're under 40, and I measure your testosterone, about half of the people that you look at will actually have a testosterone that is lower than 250, which no one will argue you should treat the person for life at that age for their hypogonadism. So you have to, before you treat, make sure that they don't have an abnormal sex hormone binding globulin, because these guys are not hypogonadal on the whole. They're just normal guys who happen to have low testosterone as opposed to high testosterone. So be aware of this. So testosterone and aging, we talked about the decline. Half of that 1% decline is obesity, that middle-age spread. So if you don't get obese, or you stop the person who's obese, you'll do better. And the key questions with aging are denclining testosterone levels clinically relevant, is testosterone substitution in older persons beneficial, and what are the risks that are available. And low testosterone does not predict death in any of the studies that we have done, but we have looked at either very healthy or very sick people. If you look at the combination of sick and healthy people, testosterone goes down if you're sick. Sick people have low testosterone. Much amazingly, sick people also die. So if you're sick, you have a low testosterone. Low testosterone predicts death. Makes sense to me, but just so you understand that literature is all related to having a group of sick people here and a group of healthy people there. Sick people have low testosterone. Non-sick people have high testosterone. So most probably doesn't have much effect. So Shakespeare said the 6-age shift into lean and slippered pantaloon with spectacles on nose and pouch on side. His youthful hose well saved to world too wide, for his shrunk shank and his big manly voice, turning again towards Charlie treble pipe and whistles any sound. If you see an 18-year-old like that, they're hypogonadal. You see an 80-year-old like that, they're old. It's very simple. They're not necessarily different. So we showed many years ago that actually half of people who have low libido have either a problem with their bioavailable testosterone or their testosterone receptor. The other half have something else that gives low libido. So testosterone is only responsible for low libido in half of people. And if you give testosterone to people who that's not the cause, testosterone doesn't make them better. You've got to treat the depression or the other thing. And testosterone will give you a stronger erection. It's very important. If you've got low testosterone, that's how you fix the erection. And testosterone castration decreases messenger RNA nitric oxide. Testosterone improves nitric oxide, which is important for the phosphodiesterase inhibitors to work. So if you have low testosterone and I give you Viagra, it will give you a soft erection. If your testosterone is normal, or I make it normal, you get a hard erection. There are lots of papers that have been coming out saying, if I have a normal testosterone and I give you testosterone, I don't get a harder erection. Well, no, you don't. You've got to have a low testosterone to get the effect of testosterone. Something that seems obvious to me, but is not obvious to some very famous people in this field. Many years ago, we showed low testosterone is associated with poor muscle function, and we then showed that Dr. C, when she was here, showed that testosterone improves muscle strength. So we thought, what about if we take people with normal testosterone levels and give them a low level of testosterone, up it a little bit, how will it work? And it actually gives you lots of muscle. So if you want muscle and get rid of fat, it's great for you. It does nothing for strength. So to improve strength, you've got to be hypogonadal and get a reasonable amount of testosterone. And that, again, is important to recognize. I'm not going to tell you how it works because it doesn't really matter. But this is important. Testosterone works as well as basically the drugs, Plato for peripheral vascular disease, as the pulmonary function, the drugs for pulmonary disease that are available, the endothelium antagonists and things like that, in increasing 6-minute walk distance. It's not great, it's a small amount, but it's no better or worse. However, if you have heart failure, testosterone miraculously improves your function. It's most probably the one place where testosterone should be used to improve function, because there are now 6 good studies, all show the same thing, and in women it shows exactly the same thing. So both of those are reasonable. Testosterone is associated with bone. I give you testosterone back, you'll improve the bone, but it's not supposed to work that way. Low bioavailable testosterone in men, lousy cognitive function. If you give testosterone back to animals with Alzheimer's disease, they think better. If you are a person floating around with mild cognitive impairment or Alzheimer's, your testosterone is very low, and it's possible that giving testosterone back will improve memory. Testosterone can be used in people with prostate cancer as long as their PSA is low, less than 1, once they've been treated. So I've told you testosterone makes you stronger, better memory, increases your hematocrit, makes you more virile, and most probably decreases hip fracture. So the ADAM questionnaire from St. Louis University is here, and just very quickly, this was created because I was asked by a drug company in Canada where I convinced all Canadian physicians they had to get a bioavailable testosterone, which was expensive. They didn't like to do this, so the government said, you've got to have some sort of test. They phoned me and said, can you come up with a test? And I said, yeah, anybody can. It's sort of simple, the questions you ask. They said it should be a little sexy. So this is a little sexy test. And basically I said, when do you want it? And they said, oh, we need it by tomorrow morning because all the family practitioners are coming in and we're training them on your test. So I said, fine. We doubled the amount of money that SLU got. So SLU got like $50,000 for this or something like that. And so I got home from the nursing home at 8 o'clock that night. I did not want to do this. So I did what I always do when I'm desperate. I went to the toilet. And I wrote on the toilet paper this questionnaire, which was typed the next day and sent to them. And this test questionnaire has been used very close to 1 billion times around the world. If I had copyrighted it or even said I wanted to copyright it, I would also be on my yacht. Yeah, I've had lots of opportunities to be on my yacht, but it's a free test. It doesn't work very well, but it sort of works as well as any of the other tests that people have gotten 5, 10 million. So this one here, they got 5 million euro to develop. This one here that doesn't work, they got 10 million out of the NIA to develop. So be fair, this one, which I got 50,000 in 20 minutes on the toilet, works as well and better than people who got a lot of money to do it. So if you've got low testosterone, you do symptom screening. If it's positive for depression, you treat the depression. If not, you get total testosterone. If it's less than 300, you can go ahead in older men and have a 3-month treatment trial. Somewhere between 300 and 500, you should get a bioavailable testosterone. if you don't get any symptom relief, you should stop the treatment after 3 months. And there are a lot of males who are okay with stopping, and there's another subset who aren't. I will tell you 25% to 30% of the studies we've done, the positive response is placebo. So placebo works very well. Side effects, the big one is hematocrit should not be greater than 55. It does not cause cardiovascular disease, despite what people say. And the contraindications are prostate cancer, a PSA greater than 4, prostate nodule, and American Neurological Score greater than 22. But I'll tell you, these are the people who get better. They have great streams. This is the best way to treat urinary problems in men, and that really works. When we were doing a ton of this in the clinics before Viagra came available, the urologists used to send the patients to me before they did surgery because we fixed them. Hematocrit greater than 52, this is the one absolute contraindication, because if you go above 55, people get strokes and they get heart attacks. Severe sleep apnea is nonsense, because if you treat them by 6 months, they actually do better. They get worse for a little bit, and we've already shown you class 4 heart failure actually gets better. So the stuff that was supposed to work, and here what you can give. You can give injection patches, gel, oral, inhalation, pellet, buccal or sublingual. I personally think that getting people to inject themselves every 2 weeks is the only way that's worthwhile. The others don't give a high enough testosterone, and they give a steady testosterone, and the problem is with a steady testosterone you don't fix the receptors properly. So this is just showing you that testosterone and enanthate work. Undecanate, it can be is an injection that can be given every 3 to 4 months. So it's like giving pellets. You can give it if you want to do it. You monitor with a PSA yearly, rectal, every time you see the patient, hematocrit, and if you're not giving injections, you get a testosterone level. If you're giving injections, you don't have to get a testosterone level, and basically you treat for symptoms. So to conclude, sexuality is important to the quality of life at all ages for some older persons, and that's what you have to remember. So what comes back to is talking to people and understanding what they want and why they want it. You should always talk about sex with a person without the partner present. My favorite patient was a 90-year-old male who lived in an apartment complex, and I saw his wife and his wife's best friend. His wife's best friend lived on the floor below them, and I talked to him first about sex with his wife present, and she said, no, neither of us care, it's not important. And so eventually he called me and he said, I'm coming back for an appointment without my wife. And he came back and he said, well, I need to be treated. And so we had a long conversation, and it turned out he and his wife's best friend were having sex because his wife slept from 2 to 4 every afternoon, and he'd go downstairs and have sex. Okay, and it made him happy, and everybody else seemed happy. So I had to work out a way to treat him. So, but this the point is, as a good geriatrician, you take a good history and you work your way through what the person needs. And if you don't do that, you're not being reasonable in giving a good quality of life. And with that, I can stop, and if there are any real questions, you can ask them. Yes, Patty?
So if a person's on injectable testosterone and they're still tired or having symptoms, you don't check a testosterone level?
No, because you know that you're getting very reasonable levels. Like injectable at 200 goes up to about 1,000. What you do is, if they tell you they're still tired, you can give it every week as opposed to every 2 weeks. You can change the amount of time you give it, and it either works or it doesn't. But testosterone, once you've given an injection, goes up to 1,000 and comes down to about 200 over a 2-week period. So where are you going to measure? You've got to decide which day you want to measure. It's a total waste of time. It costs money, and it's not useful.
Just wasting the patient's money.
No, it's my money. These are Medicare patients. You're wasting my money. Okay, I pay taxes. Any other questions? Going? Good? No? Okay, so you're all going to go and ask about sex now. and you're all going to know how to do it, so I don't have to treat all the people with sexual problems. Okay? I can't find anybody, by the way, in endocrinology who wants to take over my sex patients, and there are a ton of them, so we'll all come to geriatrics. I'm just warning you guys. I thought I could give them to the endocrinologist, but they don't want them, so you're going to get them all these old guys on testosterone.
Medicare pays for pellets.
I know Medicare pays for pellets. Not, they shouldn't pay for women for pellets. I know they do, if you know how to cheat.
Some insurances don't care. Some insurances won't care.
Yeah. But as I say, for women, I use no testosterone here. Okay, thank you all very much. Bye.
Thank you.
It's $30.
Most probably mine.
For some reason, they won't get it run.
I just, funny. Where's the battery?
You've got the thing.
So they have any kids who they want to read it.
They fax me.
Maryland thinks it's
Thank you, Dr. Morley.
Thank you.
Hey, Dr. Morley, have you met Leslie Ann's youngest daughter? This is her first grand round, and here she is listening to Morley and such.
You have nothing better to do than come together about this. That's
I
what I
this is Patty. This is Leslie.
Hi, Leslie.
Take a picture of her face and send it to her mother. I said, Ann, you should see my she's
Together.
I want to get into
Together.
that. You should have called Ann. We could have talked about sex with Ann here as well.
Actually, about Jacqueline.